So we're really going to kind of get into the meat and potatoes of, this semester as it pertains to peripheral arterial disease and arterial exams. So please let me know if I'm going too fast. You need me to slow down. Um, if you need a cup of water or a little bit of food, it's going to be a long lecture. We're going to cover a lot of material in the next few weeks. All right. So general considerations, like I said, any indication, or we need an indication for doing a peripheral arterial exam or for any exam. Like we said, an indication is a diagnostic reason why we're performing this exam. So a physician is responsible for ordering a diagnostic test based off of common indications, contraindications, and limitations. Other data to assist. So some other data to assist in making that diagnosis is going to be, physical exam. So that's why we get practice, assessing, doing a physical exam, looking at the patient, assessing their legs, looking for wounds, discoloration, certain features that might indicate, potential either arterial disease or venous disease. We'll look at lab results, lab factor, blood work. We understand patient's history because there are certain risk factors that will predispose patients to, developing peripheral arterial disease. So it's important to know their medical history, surgical history, because all that, will lead to a potential diagnosis. And some of those things we also include in our, preliminary reports. So peripheral arterial disease, PAD. So you might see it oftentimes abbreviated as just PAD. So peripheral arterial disease is a common circulatory problem in which the arteries are narrowed, and this narrowing of the arteries then reduces the amount of blood flow or the volume of blood flow to the extremities, or that can pass through the extremities. So we'll learn about some of the different things that can potentially narrow the vessel and limit that blood flow. So we'll discuss patient history, the physical exam, and some therapeutic interventions as it pertains to peripheral arterial disease. So we'll go over specifically signs and symptoms, risk factors, the mechanism of the disease when we're doing that physical exam, some of the things that we're looking for, as well as some therapeutic interventions for patients who do have peripheral arterial disease. So in terms of patient history, so a lot of this, the degree to which the disease produces signs and symptoms depends on the location and the extent of arterial involvement. So what that means is, where the patient is feeling those potential symptoms, where they're feeling the cramping, the claudication, the rest pain, where they're developing the ulcers, depends on where that potential blockage or narrowing is. And that's really our job, is to try and help the doctors to determine what segments of vessels are diseased. Where is that blockage? Where is the narrowing? Where's that atherosclerotic plaque building up? Typically, the more severe the patient's symptoms are, the larger the extent of vessels that are involved. Maybe there's multiple vessels that are involved. So the approach the patient with suspected arterial disease, we have to establish if, is that vessel just narrowed? Is there just stenosis, or is it completely occluded? Is it completely blocked? Identify, the sites of involvement, sites of involvement, the nature of the underlying disease. Again, we're going to assess risk factors and that could contribute to the disease, and understand the mechanisms of atherosclerosis and peripheral arterial disease. So some terminology. So you might hear these two terms, you might have heard these two terms, arterial sclerosis and then atherosclerosis. So they're kind of similar, they go hand in hand, that one creates the other. The way I always remember the difference between the two is arterial sclerosis just refers to the hardening of the arteries. So for me, art is hard. I'm the worst artist in the whole world. My pictures suck. So for me, art is hard. So I remember arteriosclerosis is the hardening of the arteries. So this is when the arteries lose that elasticity, that contractility. Atherosclerosis is that deposition, that depositing of those fatty plaques, those cholesterols, the lipid cholesterols, into the arterial lining. So the process of atherosclerosis, when those plaques are getting deposited into the artery, into the arterial walls, leads to the narrowing, but it also leads to arteriosclerosis, the hardening of it as well. So this is the medical term for atherosclerosis. It's arteriosclerosis obliterans. So obliterans means I see the word obliterate, meaning that lumen is getting narrower and narrower and narrow. So, that space where the blood flow can pass, eventually, if it becomes completely occluded, it's completely obliterated. It's not there anymore. The term ischemia, so we use that to describe an area of tissue or organ where there's diminished blood supply. So there's diminished blood flow getting to that particular tissue bed or organ, is the term, ischemia. And that can lead to, impacts and potential damage to those tissue beds or organ due to that diminished blood supply or diminished blood flow. So we'll talk about some of the different things that could cause, ischemia or reduction of that blood flow to an organ or tissue bed. So when we're talking about peripheral arterial disease, you have to just keep in mind that peripheral arterial disease, the most common form of it, when we're talking atherosclerosis, it's a very slow process. So it takes a lifetime to develop those atherosclerotic plaques. You're not going to be an 18-year-old kid walking in and all of a sudden you've got, atherosclerotic plaque all through your body. That usually doesn't happen. I mean, you would have to have some severe underlying medical condition, that would predispose you to developing those atherosclerotic plaques. But generally, it takes a lifetime, to develop. So we're talking, older population, elderly population. So because it takes a long time, we refer to peripheral arterial disease as a chronic disease. So you'll learn the difference between acute and chronic. Acute is sudden onset. So a patient is totally fine, normal, going about their day, no pain, no symptoms, and all of a sudden they develop symptoms out of the blue. So that would be an acute disease process that suddenly rapidly developed, and there's a sudden onset of symptoms. With chronic disease, like I said, it's a slow process. So the symptoms start to appear and then they get progressively worse and worse and worse as the disease continues to get worse and worse and worse. So with peripheral arterial disease, one of the first symptoms that shows up is claudication. So this is one of the questions that we were asking when we're doing the PVR-SLP. So the definition of it is a muscular cramp or ache that occurs during exercise or walking and is relieved by rest. So that symptom claudication, the most common cause of it is going to be atherosclerosis, that buildup of those atherosclerotic plaques. So something about this symptom, it's repeatable. So we can reproduce that symptom if we put the patient on a treadmill and exercise them. And so they start walking on the treadmill, that symptom can be reproduced. All right, I'm starting to get that cramping again in my calves or in my thighs. With claudication, the disease segment, so where that blockage or that narrowing is always proximal to or at the level of the symptomatic muscle. So if I'm having that cramping in my calf, the disease segment could be, where that cramping is or any vessel proximal to it. So, if it's in my calf, it could be popliteal artery, it could be femoral artery, it could be common femoral artery, it could be external iliac artery. If it's both legs, it could be in my aorta. If it's in my aorta, I would have cramping probably in both calves at that point. So just remember that the disease segment is always going to be proximal to or at the level where that symptomatic muscle is. So if it's in the thigh, the disease segment can't be popliteal because my cramping's in my thigh. So just think about it. The muscle's going to cramp because it's not receiving blood supply. It's not receiving adequate blood supply. It's ischemic. That muscle's suffering ischemia. So that means there's limited blood flow getting to that muscle. So if the disease is down here, that just doesn't make sense. There's enough blood flow getting to that muscle. The disease is down here, that just doesn't make sense. If the disease is down here, the cramping and pain is going to be at that level or below it. It's because the blood flow can't get to that muscle group. So just imagine the blood flow, it's traveling down the legs. It gets to that narrowed area. And, you're reducing the amount of blood flow. So anything below that narrowed area is fair game for symptoms, for cramping, ulcers, depending on how severe it is. Claudication, sometimes they refer to it as what's called disappearing pulse. So we'll learn when a patient does have claudication and they start to exercise, their pressures drop precipitously and the pulses really become diminished. Could even be to the point where you don't even palpate them anymore as the pressures and the pulses drop so much. So sometimes referred to as that disappearing pulse. So that's why the symptoms come on with exercise, because those pressures drop, the tissue beds become more ischemic, and then that patient has to, stop what they're doing. So they have to rest, and then the pain goes away. There is a potential condition called pseudoclaudication. So pseudo, that prefix means false. So it's false claudication, and this is typically due to a patient that's experiencing pain or cramping that's more related to either nerve or skeletal muscular issues. So maybe they have sciatic nerve pain. Anyone who has sciatic nerve pain, they get pain that kind of shoots down the leg. So it might mimic, pain or cramping in the muscles, but it's more related to nerve or maybe a spine condition, degenerative nerve disease. So moving up in severity, the next stage. So once the patient progresses from claudication, they progress into eventual developing rest pain. So the plaque and that narrowing is getting worse. There might be more disease segments involved. So the extent that disease is getting worse. So this is pain that develops in the toe or the forefoot when blood flow is insufficient to maintain cellular function at rest. It's referred to as elevation pallor or dependent rhubarb. So this patient has worse peripheral arterial disease. So at night when their legs are elevated, their feet and their calves aren't getting blood supply because their feet are elevated. So when they're up walking around, gravity's helping to bring blood flow down the legs. But as soon as they put their feet up, their feet get very cold, very pale, and then they start developing pain, cramping, tingling sensation in their feet and their calves. And it wakes them up in the middle of the night. And then they get relief by putting their legs over the side of the bed and letting gravity do its thing and bring some blood flow back down towards to the feet. Like I said, this is more severe, so it usually indicates patients that have multi-level disease. So it's more than just one artery that's involved. So they might have, femoral artery disease, popliteal artery disease, and then maybe some disease in the smaller vessels of the calf. With patients who are experiencing rest pain, there's additional testing that we could do, called an exercise stress test, where we put the patient on the treadmill, have them exercise until they experience those symptoms. So that's something that we would do with claudication to kind of rule out, is it pseudoclaudication that the patient's having, or is it true claudication? And we can get those results from an exercise test. But if they're experiencing rest pain, there's really no need for us to do that exercise stress test. And we'll talk about another one, this reactive hyperemia test, because we already know they have significant disease. So this will definitely be evident when we do our test. So with this pseudoclaudication, the patient's coming in there, with claudication, patients coming in there, they should be relaxed, relatively relaxed. They're not exercising, they're not doing anything to cause those symptoms. Their symptoms are just when they exercise, when they're going upstairs, they're doing something strenuous. So their resting study could potentially be normal. So we don't have an explanation for what they're feeling because their resting test is normal. We're getting fairly normal pressures. Doesn't really look like there's any disease. It's only when they exercise that those symptoms come out. So that's why we have to do an additional test, that exercise treadmill test, in order to make, that diagnosis sometimes. So moving up and now in severity, a patient might develop wounds and ulcers. So arterial ulcers are very deep. They're very painful. These patients will also have trophic changes. So there'll be changes to their skin as well. They'll have shiny, scaly skin. They might exhibit thickened toenails. If you have male patients, there'll typically be loss of hair on the shins and the tibia area, the bony prominences. Patients who have these ischemic ulcers that are unlikely to heal if they have very low ankle pressures. So we're talking ankle pressures that are less than 55 millimeters of mercury in non-diabetics. We said diabetics, their arteries tend to be calcified, so their pressures tend to be falsely elevated because of that diabetes. So that pressure measurement is a little bit higher for diabetic patients. But you guys have kind of got an idea of like what a normal ankle pressure is. Again, it should be similar to your brachial. So we're talking about, if your brachial pressure is 100 and your ankle pressure is 55, that's an ABI close to 0.5. So that's getting pretty low now. After ulceration, if the patient has these wounds and these ulcers that don't heal, that tissue can eventually start to die, and that's referred to as gangrene or necrosis. So this is tissue death due to deficient or absent blood flow to that area. So when there's areas of gangrene that's set in, those areas have to be removed because it is septic, can lead to sepsis of the patient. So those, unfortunately, those are the areas where we have to potentially amputate. So vascular ulcers are gross. So again, we see these ulcers typically on the fully prominences, on the dorsum, the ventral sides of the foot. We could see these around the ankles, on the digits, the toes. And they're very deep. They have regular borders to them. They're usually dry in nature, whereas venous ulcers kind of weep and ooze. Examples of patients that have now gangrene and some of the trophic changes. So again, you see that scaly skin, shiny scaly skin. So that second digit is completely necrotic, as well as the fifth one there. So this was kind of bringing home the point of the disease is always proximal to, at or proximal to, the affected area. So again, if a patient comes in, they're complaining of pain or cramping in the hip or buttocks. We think more aortoiliac being affected, so pain's here. The disease is going to be proximal to it. When pain in the foot occurs, it could be the disease segment, maybe popliteal level. So segment will, if there's popliteal occlusion, will affect segments below the knee. Pain in the calf, could be femoral. So it's proximal to where the patient's experiencing those symptoms. So where's the disease? Proximal to the symptomatic. So pseudoclaudication or neurogenic claudication. Again, there could be some differential diagnoses. So things like degenerative joint disease, nerve compression, or it could potentially be a venous issue. Maybe that patient has venous insufficiency that's causing their pain or their cramping. So these are the patients that would have a normal PVR SLP when they're resting. So it doesn't explain, again, the patient's symptoms. So a normal physiologic test at rest does not exclude the diagnosis of arterial obstruction. So that's why we have to exercise. And that exercise test can be used to detect early disease and also rule out, pseudoclaudication. So those were chronic peripheral arterial disease symptoms: claudication, rest pain, the vascular ulcers, and then gangrene. Patients could potentially have acute arterial occlusion. So this is now acute disease, acute onset. So potentially, a patient can develop a blood clot within the arterial system itself, a thrombosis. So again, blood flow in the arteries is moving much faster than it is in the veins. It's usually continuously moving, circulating. So the blood doesn't really get a chance to pool and coagulate and form into a clot. So I kind of think of a blood clot as like you're making Jello. When you first make Jello, it's liquid. As it starts to cool and you put it in your refrigerator, it's just sitting there cooling, it starts to harden and form into a clot, like the gelatinous, Jello mold. So that's kind of how I envision the venous system. Like if the blood flow doesn't circulate, like if I was to keep stirring the Jello, it would never form into, actual Jello. So if you keep stirring the blood flow, chances are it's not going to form into a clot. It's when it stops moving that it really gets a chance to start forming into clots. That being said, we can have thrombosis in the arterial system, but it's more likely due to some sort of embolism. So within the arterial system, the most likely source of a clot is going to be something that's being ejected from the heart. So these are patients that maybe have had a heart attack, they have an irregular heart rhythm like AFib, where the heart's not beating properly, and the blood clot actually forms in the chambers on the left side of the heart. And then when the heart contracts, that blood clot actually gets ejected from the heart into the aorta. And then once it's in the aorta, it can, essentially go wherever it wants. It can go up to the brain, cause a stroke. It can go down the aorta, down the arch, down the legs, and get lodged, in the popliteal artery somewhere or further down. So when we talk about, acute arterial occlusion, there's, like we said, a sudden onset, could be due to thrombosis, potentially trauma to the vessel itself, or an embolism. These symptoms are sudden onset, and they're very specific symptoms for the arterial system. So the patient's going to develop pain all of a sudden. So we refer to them as the 5 Ps. Pain, pallor. So pallor refers to a paleness. All of a sudden the leg or extremity gets very, very pale. Pulselessness. So they lose their pulse now. All of a sudden, you're feeling for a DP or a posterior tibial pulse. They don't have any pulses because that artery is being blocked. Paresthesia. So this is like tingling, numbness, burning sensation. So kind of think like pins and needles. Paralysis. So again, if now there's no blood flow getting to my leg and I have a blockage up here, my leg can just become completely, paralyzed. Like you don't have any control of that muscle movement because it's not getting blood. And then there's a 6P called poikilothermia. So this is an inability of your body to regulate the temperature. So that limb's going to feel extremely, extremely cold to the touch. So again, this usually results in more severe symptoms when we're talking about arterial occlusion. It's sudden onset. So remember your 5 Ps, your pain, pallor, pulselessness, paresthesia, and paralysis. So this was a patient, with acute arterial insufficiency. The skin is very pale now. It's mottled. To me, there's like little splotches of some reds and some blues in there, but it's, looks very pale. It's lost its color. So risk factors for peripheral arterial disease. So these risk factors, you're going to see them, run through anything that we're talking about arterial wise. So the main risk factors for peripheral arterial disease are going to be smoking, diabetes, hypertension, high blood pressure, and then hyperlipidemia, high cholesterol. We'll see some other, underlying or contributing factors as well, but those are the big 4. And that's why we always ask these as part of, any arterial exam that we're doing. We want to know if a patient has a history of smoking, if they have a history of diabetes, hypertension, and then hyperlipidemia. So with smoking, the chemicals in the cigarettes irritate the inner lining, the endothelial lining of the arteries, damages that endothelial lining. And when we have damage to that endothelial lining, that's when it allows those cholesterol deposits to work their way into that endothelial lining. And the body's going to try and we'll go into the mechanisms of how it actually develops in a later lecture. But the body's going to try and heal itself, and it's going to create a scar over that area where there's the damage. And it's this cycle of damage repair that ultimately leads to the narrowing of that vessel. So it's kind of scar tissue building up on layer on top of layer on top of layer, and eventually narrows that artery. In addition to that, nicotine is also a vasoconstrictant. So you're not only damaging the vessel, leading to the deposit of those atherosclerotic plaques, but you're also at the same time narrowing the vessels as well through vasoconstriction of the, the nicotine itself. So smoking is considered a controllable risk factor. So, patients can quit smoking. And by doing that, it helps the body will eventually heal itself or try to start healing itself. Bless you. Then when patients have a history of smoking, you want to ask, if they smoke, have they ever smoked? For how long? How many packs per day? So with diabetes, so atherosclerosis is more common at a younger age in diabetic patients. Again, it's one of the main risk factors when we're talking about peripheral vascular disease or peripheral arterial disease. With diabetic patients, they do suffer from neuropathy. So this is a loss of sensation in the extremities. So with diabetes as well, there's another condition called medial calcinosis or medial calcification that develops in the lower extremities. So this diabetes causes the arteries to become hardened. When we're doing this PVR SLP exam, you'll know right away if a patient is diabetic. When you inflate your cuff and you're at 250 and you still hear the pulse, their vessels are non-compressible. So they might have lied to you about their diabetes, or they just don't want to admit it. The other thing that could also cause this medial calcinosis or medial calcification would be medical renal disease. So maybe the patient's on dialysis, their kidneys are shot, and they've been on dialysis for a long time. That will also calcify the arteries. So medial is referring to that medial layer of the arteries. So that middle layer, the muscular layer, becomes calcified, becomes hardened. And that's what causes the vessels to be non-compressible. Patients with diabetes have a higher incidence of occlusive disease, as well as developing gangrenous changes that ultimately lead to amputation. So unfortunately, diabetes is one of those very insidious diseases where, if you really don't take good care of yourself, it will lead to, lots of complications. So this is also a controllable risk factor. So with this, you want to ask the patient if they're on any insulin or oral medications, how long they've been diabetic for. My wife's father, so my father-in-law, he passed away mid-50s from diabetes. He was back in Egypt. And his wife, my mother-in-law, told him, you start insulin, you're going to have to be on it for the rest of your life. So don't take insulin. And he kind of wanted to live his own life, thumbed his nose at it. My wife told me he would down like a 2-liter bottle of Coke in like one sitting. Would eat a pound of pasta in like one sitting. Like the guy he was a huge man, like morbidly obese. So like I can only imagine like what his blood sugar levels must have been. But it wasn't until like the diabetes really ravaged his body that he realized like he made a huge mistake at that point. I think he wound up into like renal failure and just it wasn't good. And they were talking about amputating part of his legs at that point, and it wasn't good. Hypertension. So high blood pressure now. So persistent high blood pressure, greater than 130 over 80 millimeters of mercury. So with blood pressure with hypertension, we have to determine, is this a result of, peripheral vascular disease, or could it be the kidneys that are causing the issue of patients who have hypertension, high blood pressure? With hypertension, there's a greater incidence of coronary atherosclerosis and the individual's susceptibility to peripheral and cerebrovascular involvement as well. So what that's saying is patients who have hypertension typically there's a correlation or a higher incidence of atherosclerotic plaque developing within the vessels of the arteries of the heart. And there's also a correlation to both peripheral and cerebrovascular involvement. So that hypertension will also contribute to that endothelial injury. So again, it's all about damaging some things that are going to damage that inner layer of the artery and lead to that cycle of injury repair. So the high blood pressure can actually tear and damage, that inner lining. So with hypertension, there's an increased myocardial demand for flow. With hypertension also, this is again a controllable risk factor. So again, you see that, so far all these risk factors are controlled. You could take your meds, control your blood pressure, control your sugar levels, control your diabetes, quit smoking. Again, with hypertension, you want to ask, if the patient has history of high blood pressure, are they on any medications for high blood pressure, how long they've been hypertensive for. Last major one is hyperlipidemia, high cholesterol. So this is an abnormally large amount of lipids in the circulating blood. And this is also closely associated with the development of atherosclerosis. So cholesterols are broken down to a couple different kinds. So in terms of the bad cholesterols, those are going to be your low density lipoproteins. So we have very low density lipoproteins. So these are patients that have elevated triglycerides. This is a major risk factor, again, for coronary artery disease, increases your likelihood of coronary artery disease. The low density lipoproteins or cholesterol in the proteins. This increases your chances of atherosclerosis. And then we have the good cholesterols. So you might hear the, good and bad cholesterols. Those are going to be your high density lipoproteins, your HDLs. And these will actually lower your chances of developing atherosclerosis. They help, promote, healthier blood vessels. This is also a controllable risk factor like the others as well. Again, you want to ask, do you have high cholesterol? Are you on any medications for your cholesterol? How long? And some of the other risk factors that can go into it, definitely patient's age when we're talking peripheral arterial disease. So again, the older you are, the more likely you are to potentially develop atherosclerosis. There is a genetic component to it. So some people are, predisposed. So there's a familial history of cardiac disease. So when we're talking peripheral arterial disease, again, there's that correlation to cardiac disease. Gender as well, more common in males. But then again, once we get into the female population, once we get post-menopause, that gap between male and female really narrows or closes. Obesity. So obesity, people who are obese tend to have lower levels of the good cholesterols, higher levels of the bad cholesterols. Obesity also kind of plays into lifestyle as well. They're typically maybe more sedentary, have a more sedentary lifestyle. So that's something you want to consider lifestyle, maybe the patient, is either wheelchair bound or bed bound or something like that, So in terms of mechanisms of the disease, so atherosclerosis. So that deposition or depositing of plaque occurs in the intima and medial layers, so that inner and middle layers of the arterial wall. So here we can see an artery kind of in that cross-sectional slice. And you can see that plaque being deposited around in that intimal and medial layers. So atherosclerosis is the most common cause of chronic arterial occlusive disease. So it's generally described as a diffuse disease, meaning that it kind of can affect, it can affect anywhere in the body and can be spread out. But we tend to get these very localized plaques that develop that become the more significant plaques. So we can have some diffuse disease, spread out throughout the body, through the arteries of the body. But where we get those areas of damage, where that endothelial layers, becomes damaged, tears, and the body has to heal and repair it, is where we really start to develop, those focal plaques, those focal areas of atherosclerotic plaque. So the most frequent site of atherosclerotic narrowing in the peripheral arteries. That's kind of like your Jeopardy question right there. That likes to show up on the vascular boards. It's the distal superficial femoral artery. So distal SFA, so think distal thigh, right in that area is the most frequent site for atherosclerotic narrowing. So it's right near the abductor canal. The second most common segment is going to be the aortoiliac segment. So where the aorta splits into the iliacs. Subclavian arteries are the most common site in the upper extremities. This can lead to, again, claudication and posterior cerebral symptoms. So if you think about the reason it says posterior cerebral symptoms, we said that the vertebral arteries come off the subclavian artery. So if I have disease in my proximal subclavian arteries, near that origin, it could impact the amount of blood flow getting up the vertebrals and lead to potential symptoms that are specific to the posterior cerebral territories. So the term embolism now. So embolism is an obstruction of a blood vessel by a foreign substance, blood clot, or a piece of atherosclerotic plaque, pieces of atherosclerotic plaque. So those plaques that are developing in the arteries, they can actually break off, embolize, travel, go down the artery, and they get lodged further distally down in a smaller artery further distal. So again, just keep that in mind. So embolism could also be, we said, blood clots in the arteries most likely come from the heart. So they embolize, they get ejected from the heart, and they get lodged in an artery. So arterial emboli is the most common cause of acute arterial occlusive disease. And we said the most likely source of that embolus is going to be cardiac in nature. So when there's embolism, there's a stasis of blood produced by a sudden blockage that results in propagation of that thrombus both proximally and distally. So what that means is, I have my artery, and then a clot, is coming down that artery and gets stuck in here. So gets lodged in there. And when it gets lodged in there, it's going to stop the blood flow. So now blood flow, can't get down that leg. Blood flow is not getting past that clot, so there's nothing there. So the blood, becomes static. It's not moving. It's not circulating. So that blood clot actually, that emboli creates more blood clot and it starts propagating. So that term propagating means extension. So it's going to propagate up the leg as well as down the leg as well. And that thrombus or that blockage, that clot's going to get worse and worse and worse. Cardiogenic, can you see? I'm blocking you. Cardiogenic emboli. So we said, again, heart most likely source. So things when there's arrhythmias in the heart, like atrial fibrillation, myocardial infarct, heart attack, these emboli tend to be fairly large and they can include major branches. So, these clots can be very large when they get ejected from the heart. Atheroemboli, those little atherosclerotic plaques, these tend to be they are much smaller in nature. So those plaques can ulcerate, they can break apart, and then travel down the extremity, and they get lodged into smaller branch vessels. So that can cause, areas of necrosis to develop where they get lodged. So we'll learn in a moment, there's a condition called blue toe syndrome, where little atheroemboli, make their way to the arteries of the foot, and they can turn one of your toes blue. Like, so patient comes into the ER, their big toe is just blue, the rest of their toe is fine. So a little piece of atherosclerotic plaque probably broke off, got stuck in an artery in the foot and the big toe, and is now turning your toe blue. I remember I had a patient that came to my department with blue toe syndrome. Look at that. And they ordered a DVT study and the veins. I'm like, you gotta be kidding me. I'm like, who assessed you? Arterial thrombosis. So may occur distal to a critical stenosis, result from embolization, trauma, or thoracic outlet compression. So now we're talking again, thrombus or clot development within the arteries. So if I have an artery in my leg, down. So we can also potentially wind up with clot formation if I have a very severe stenosis. Blood flow is getting through. It's passing through that clot. Now we've lost a lot of energy, a lot of pressure energy. We've lost a lot of our velocity trying to make our way through that blockage. And the velocities down here are very slow. They're much slower than what they were up above. And again, those slow velocities are a nice environment for a potential clot to develop or form in that artery. So we can see a distal to a critical stenosis or a major stenosis. Like we said, result from embolization. Trauma. So physical trauma is another thing that could result in blood clots. So if we have physical trauma, maybe I was hit by something, I was in a motor vehicle accident. Another form of trauma would be if they stuck my artery or vessel with a needle, trying to either draw bloods, arterial blood gases, or they were trying to put an IV in, they hit my artery instead. So that's also considered trauma to the vessel. That trauma is another thing that leads to endothelial injury and then the potential development of blood clots. Thoracic outlet compression, so that's thoracic outlet syndrome. Yeah.
Would the clot form below the stenosis?
Below, distal, yeah, distal to below the stenosis, yes. Yeah, up here, the blood flow it's still traveling fine, so it still has all the energy from the heart, so it's moving fast. It's trying to pass through, it's gonna accelerate through here, through that blockage, but once we get past it, it's lost all that energy. You'll get turbulent flow on that side, and then further down, the velocities are way diminished. So, we could be like 120 up here, and then down here, we're like 15, 10, 5 centimeters per second. So it's much, much slower on the other side of a critical stenosis, I guess.
Thank you.
So with thoracic outlet compression, that's when we get compression of the vessels in the upper extremity between the first rib and our scaling muscle. So it could be in different positions where the patient puts their arm in a different position. That leads to compression of that subclavian vessels in the thoracic outlet. So when the vessels are compressed, it's the same thing as having, a blockage or a thrombus. So if I pinch off that vessel, and narrow it because of compression or something's pushing on that vessel, that could lead to clot formation, if my vessel's getting squeezed, by something. We'll go more into thoracic outlet syndrome. We'll have a whole little class going over thoracic outlet syndrome. So occlusion, so again, this thrombus, the clot within the vessel, may cause occlusion, meaning that the vessel's completely blocked, or partial occlusion. There's still a little bit of flow getting through that vessel. So this is an example now of arterial thrombosis, so actual clot within the artery itself. So we have two views. We have a sagittal view of that artery and then a transverse view of that same artery. And you can see there's a little stream of color right down the middle of that vessel, but there's clot and thrombus along both walls. Now I rotate, turn on it, you get a sagittal view. So same thing. I see clot all adhered to the wall of that vessel, and a little bit of flow still within the center of that artery there. So this was a patient's axillary artery. So blood clots you can actually see on ultrasound. So we could see them, especially depending on the age of them. The older the clot is, the more brighter, the more echogenic it appears. Clots that are very new, very fresh are more hypoechoic or even potentially anechoic. So this is probably a fresher clot. This is definitely an older clot. There's more echogenicity to it. It's brighter. So with arteries, another thing that we worry about or we're looking for or concern ourselves with is aneurysm. So aneurysm is defined as dilatation of an artery or a blood-containing tumor connecting directly to the lumen of the artery. So a vessel is said to be aneurysmal when the diameter at the point of interest is 1.5 times greater than that proximal segment and distal segment. When we're talking about aorta and iliacs, we have specific diameter measurements. Anyone remember aortic diameter measurement? Consider an aneurysmal. Over what? Greater than 3 centimeters. Good. So greater than 3 centimeters for aorta is aneurysmal. And then the iliacs, common iliacs, 1.5 centimeters. So those are our two magic numbers when we're talking about aorta and common iliacs. But if we're just happen to be assessing, like say, popliteal artery, that's another one that could potentially become aneurysmal. We have to compare the segment before and the segment after it. So So we'll be imaging, the vessel, the artery. We'll see an area where that vessel dilates. And we're gonna measure the diameter of that aneurysmal area at its widest point. And then we compare it to, the diameter that we get before the aneurysmal part and the diameter that we get after that aneurysmal part. And we see if it's, 1.5, 1.5 times greater. So, if we go from 1 centimeter to 2 centimeters, that's doubling. So that's 2 times as great. That's an aneurysmal segment. So even if the patient has small little arteries normally, we just use that ratio to decide if it's aneurysmal or not. Because again, we're all different, like my vessels are gonna be way different than, LeBron James or something, Some basketball players got ginormous vessels. When we're talking about aneurysm, the most common location for an aneurysm in the arterial system is going to be infrarenal. The infrarenal aorta. So that means the aortic segment below the level of the renal arteries, or below the level of the kidneys. So we refer to it as the infrarenal aorta. So inferior to the level of where the renal arteries come off. So just kind of envision where the renal arteries come off. The most common location for an aneurysm, when we're talking any aneurysm or any artery, is going to be that infrarenal aorta. So we refer to it as a AAA, an abdominal aortic aneurysm. And where is that abdominal aortic aneurysm or that AAA? It's going to be below the level of the renal arteries or infrarenal, the infrarenal aortic segment. The causes of aneurysm, sometimes, they're just unknown, but they may include some of these reasons. So poor arterial nutrition, might be a congenital defect that they're born with. Infections can cause an aneurysm. So if an infection gets into the blood vessel, into the system, these are referred to as mycotic aneurysms when they're caused by an infection. Trauma to that vessel itself can lead to an aneurysm. Again, we said trauma could be physical trauma, or it could be, trauma as a result of a needle stick. Atherosclerosis, again, also leads to the potential development of aneurysm. So the plaques are entering into those vessel walls, into the medial layers. It weakens that medial layer, which can eventually lead to, development of aneurysm. So a catheter insertion, we said, another form of trauma, inflammation. With congenital defects, I mean, there's certain autoimmune, I guess it is autoimmune, but Marfan syndrome is a big one that leads to aneurysm, Ehlers-Danlos. You have also want to put on here hypertension as well. So hypertension, then another thing that damages the arterial walls, could lead to, development of aneurysm. So when we're talking about aneurysm, the main complications that we worry about obviously are going to be rupture. So as this vessel gets larger, dilates, the main thing that we worry about is that artery potentially rupturing. That could lead to, catastrophic, blood loss. Because again, the most common place is going to be your aorta. Your aorta ruptures, you're essentially toast. The other thing with an aneurysm too that we potentially worry about is distal embolization. So with these aneurysms, as blood flow, is coming into that aneurysmal area, the blood flow actually slows down. So blood flow is coming into that aneurysm. As it enters in, it starts to slow down. As it enters in, it's got more space to move. So I'm just kind of drawing like little arrows here. So kind of think of your blood flow, like you're in a stream, you're on a river, you're on that raft going into a river, going down the stream, and then you enter into a calm lake or a pond or like a big lake. Now the water's nice and tranquil. You're in this big pond, this big lake, So that's kind of similar to what's going on, when you enter into an area vessel that's aneurysmal. The blood flow slows down precipitously, so your velocities all of a sudden drop down. Because again, those velocities now are dropping down, prime condition for development of clot. So you'll oftentimes see aneurysms now. There's thrombus that's developing along the walls of that aneurysm now. So we get blood clot forming in there. And then where there's blood clot, there's potential for embolization. Little pieces of this blood clot, breaking off now and traveling and, breaking off and then continuing down the leg, down the extremity. So again, if we have also that blood flow slowing down, that aneurysm could cause ischemia. So there's diminished blood flow getting down the rest of the leg that could lead to symptoms from either thrombosis or embolization. When we're talking about the peripheral arteries now, the most common location for a peripheral artery aneurysm is going to be the popliteal arteries, so behind the knee. So that's typically where we see it. Most other arteries are not going to become aneurysmal. It's very, very uncommon, very unlikely to find them in those other areas. But popliteal artery definitely. Like I've definitely found plenty of popliteal artery aneurysms. Just something for you guys to know that there's actually a correlation between popliteal artery aneurysm and abdominal aortic aneurysm. So with AAAs, this abdominal aortic aneurysm, most people don't even realize they have that until they get some sort of imaging. Maybe they're going for like a CT scan or something, and they find it incidentally. So they often refer to that AAA as kind of like a ticking time bomb. Like unless you're exhibiting some sort of symptoms, you may not even know that you have a large abdominal aortic aneurysm. So because that, have that aortic aneurysm and you're getting diminished blood flow down the rest of that aorta, that patient might have symptoms in their legs. So they might be coming in for an arterial test because they're having symptoms, they're getting poor perfusion to the legs. You scan their legs, you do their ultrasound, you find popliteal artery aneurysms on both sides. You're like, oh, look at that. That, is enough indication for them. The doctor should then go look at that. So you might save that guy's life by finding that and making that correlation and, bringing that to the doctor's attention. Be like, look, I saw these popliteal artery aneurysms. I imaged them. I documented it, and that's going to potentially lead to either an ultrasound or a CT to look at their abdominal aorta. Yeah.
Would it have to be the aneurysms found bilaterally, or could you just find one on one side and it can still indicate an abdominal?
They're most frequently bilateral from what I've seen. Like usually if it's on one side, it's on the other. Not necessarily. So I mean, if you do find it on one side, could potentially, also have an abdominal aneurysm. But then I must say like 99% of the ones I've seen are bilateral. They have them on both sides. So in terms of types of aneurysms, so we have a couple of different types of aneurysms. We have true aneurysms, dissecting aneurysms, and then pseudoaneurysms or false aneurysms. So a true aneurysm is when all three layers of that arterial wall dilate. So we're talking, the internal media and adventitial layers, the outer layers all dilate. We'll get into, there are a couple of different shapes in terms of true aneurysms. Dissecting aneurysm is when we actually get a small tear in the intima and we get separation of that intimal, separation between the intimal and medial layers. So with the dissection, so you have your outer layer, your medial layer, and your intimal layer, your inner layer. So that intimal and there's a small tear in between that intimal and medial layers. So that could potentially allow for or creates a cavity where blood flow can enter into that separation. So I can have blood flow, coming down the leg or up the leg or down, or I'm sorry, not up the leg, but down the leg or through the extremity. And then it creates actually what's called a true lumen and a false lumen. So this would be your true lumen. Bless you. And false lumen. So with this dissection, so that separating or that tearing You can imagine it's very painful. Like your arteries are literally the inner layers tearing off of your arteries. This could put you guys potentially get progressively worse and worse. So, that tearing could continue to extend down, if it's not surgically corrected. So within that false lumen, blood flow can enter in and then it could hit where it's still connected and then reverse back out. So you can have bidirectional flow within that, false lumen. In addition to that, within that false lumen, it creates a nice little pocket where blood clots can start to form. So it can start to become thrombosed within there. As that becomes thrombosed, that false lumen can get larger and larger, compressing your true lumen. And now you've got not only the dissection, but you've got a stenotic area now where it's narrowed. So this dissection also creates an area of stenosis as well. So that tearing, that separation can spread both proximally and distally. So it could tear from both ends. It can get worse in that direction as well. So those of you in cardiac, you'll learn that dissection most commonly occurs in the proximal aortic arch. And that tear can actually go work its way back, and you can get some tearing all the way that extends right up to the aortic valve and affect the closing of the aortic valve. It can influence the coronary arteries that are coming off right there. So it's a big deal when we're talking about, aneurysms. I'm dissecting aneurysms. Then the last one is a pseudoaneurysm or false aneurysm. So these have what's referred to as a pulsating hematoma. So if you break down that word hematoma, the first word hema means blood. So it's a pulsating mass of blood or collection of blood. With the pseudoaneurysm, there's a very distinct color flow pattern that resembles a yin yang. And these most often will occur as a result of catheterization. So, these are patients that went to the cardiac cath lab in the hospital. They did an interventional procedure where they went into the artery intentionally to do the procedure that they need to do. So either place a stent, take a look at the coronary arteries of the heart. They did whatever procedure they need to do, and they access through the common femoral artery or that proximal femoral artery. So it's going to be up in the groin. And then when they remove the catheter, the artery doesn't close off. It doesn't seal off properly. They don't apply enough pressure after the procedure to stop the bleeding. And there's still a hole in that artery and blood flow is extravagating. It's leaking out. And the body actually tries to contain that bleed by creating this hematoma. And you'll see that there's a thin neck of blood flow that leads back to the main vessel that connects that hematoma, that pulsating hematoma, to the native vessel itself. This was showing a couple of different, again, types of aneurysms. So we said true aneurysm, all three layers dilate. False aneurysm is when we have that pulsating hematoma that's connected to the main artery, where you're getting blood flow leaking out of that main artery. I personally don't like this picture too much. It makes it look like it's that adventitial layer still intact. It really isn't. The body is just kind of encapsulating, creating that hematoma. And then this is supposed to demonstrate a dissection or separating between the inferior and medial layers. But so this is a little bit better, showing dissection and pseudoaneurysm. So again, we said dissecting aneurysms. So for right now, you guys don't need to know the different types. But there's a couple different classification methods. There's a Stanford and a DeBakey. We'll get into third vascular class. And we'll look at, what segments of the aorta are actually dissecting and how we classify them. Again, just keep in mind, the majority of dissections are going to be in that aortic arch in the proximal thoracic aorta. So for abdominal ultrasound, DMS students, you're probably not likely going to encounter, a dissection in the course of your careers. So this was demonstrating a pseudoaneurysm where they've punctured the artery, through that catheterization, and now we're getting leaking of that blood flow out of that vessel. And then again, the body's encapsulating in that hematoma. So that's the actual pseudoaneurysm. And it has that pseudoaneurysm, that hematoma is connected by a thin channel of blood flow referred to as a neck. So this is the neck of the pseudoaneurysm. the actual pseudoaneurysm itself. When we get into imaging these, there's a very specific, protocol and images that you require when you're assessing and imaging a pseudoaneurysm. So this is shapes of true aneurysm. So when we're talking about true aneurysms, there's two distinct shapes. There's a fusiform aneurysm. So that means that the dilatation is diffuse and circumferential, so all walls are dilating equally. Versus a saccular aneurysm, where it just you get a localized outpatching of that artery. So your fusiform aneurysm, it's gonna look something like that, where it dilates, circumferential, and then your saccular, could look something like that. Fusiform is way more common, so you're more likely to encounter a fusiform aneurysm than a saccular. Usually this might be a result of maybe like a mycotic infection. There again, look at that, I'm a step ahead of myself. Diagrams your fusiform aneurysm and then your saccular aneurysm. So these are more likely, again, due to some sort of trauma or either mycotic infection. So when it comes to measuring an aneurysm, again, we just want to be careful and cognizant that we're measuring in the correct plane and orientation. So we want to measure the maximum diameter of that aneurysm at its widest point. So again, some are going to be in the abdominal aorta, below the level of the renal artery. So here your renal artery is coming off that inferior abdominal aorta. Because of the weight of that aneurysm, it can actually shift it. So it tendency that the aorta isn't running straight up and down anymore. It's actually shifted or changes its course, becomes a little more tortuous. So again, you just have to make sure that you're aligning your transducer, your probe, to the way the aorta is running to do your maximal diameter measurements. So again, if you're just kind of going straight across, you'll be overestimating it. This will be underestimating it because we're not at that widest point. So again, you want to find that widest point and measure perpendicular to the course of the aorta. So the aorta is running this way. We're at 90 degrees when we're doing that diameter measure. So a 90-degree measurement. So this was showing a fusiform aneurysm now in the subclavian axillary segment. So they're comparing the diameter proximal, I'm sorry, so this is an axillary. So that would be distal, is it right or left? Yeah. And then the aneurysmal segment. So it's going from, around 4 millimeters up to 9.3 millimeters. So it's more than doubling. So that definitely fits the criteria for an aneurysmal segment. And with color on, there was no visible thrombus. So it fills completely with color now. So there's no evidence of thrombus within that actual aneurysm. Whereas this aneurysm is a femoral artery aneurysm. Sagittal view, you could see where the vessel actually dilates and then narrows again. So that's the outer wall. And then there's some hypoechoic or darker echoes within it. Both walls, so anterior and posterior walls. And then with color in our transverse view, you can see that there's actual thrombus all the way circumferential around that aneurysmal vessel. And then this is just the area of the patent lumen where blood flow is still getting through. So when we're measuring aneurysms, we're going to always measure it in two planes, in transverse as well as in sagittal. Essentially, your sagittal measurement is still an AP, so it should be pretty similar to what you're getting in that transverse view. So this was showing a 2-centimeter aneurysm with a regular intimal plaque. And when we measure aneurysms, we're always going to measure outer to outer. So we want to measure the outer wall of that vessel to the outer wall of that vessel. So that's something we also want to take into consideration. Arteries and aneurysms are always measured outer to outer. So in this case, normal popliteal diameter is around 0.5 centimeter. So they were measuring here 2 centimeters, so that's, 4 times the normal size. So another large popliteal artery aneurysm. That's primarily thrombosed or transverse. This is all thrombus, it's all clotted off in a little area. That's still patent where blood flow is still getting through. So you document, that the aneurysm in its entirety, as well as you would Doppler to see the flow characteristics through that aneurysm as well. So you get velocity measurements, Doppler tracing. So dissecting aneurysm. So we said now this was separation of the intimal and medial layers. And these are something that we can also potentially see on ultrasound as well. When we get that separation of that intimal layer, it creates something what's called an intimal flap. So that intimal flap is a lot easier visualized when we're in transverse, when the vessel is a circle, and we see this echogenic line kind of traversing or coming across the vessel. So here again, transverse, and you see that echogenic line, that intimal layer as it crosses across that vessel. So in transverse, we should be able to see that intimal flap. And then if I turn on sagittal, that intimal flap could still potentially be visualized there as it's coursing through the vessel. So that's what they're doing here. They're just kind of turning on that vessel and you can see that intimal flap as it's coursing through the vessel there. So we said now with that dissection, it creates a true and a false lumen. So with dissections, we can get a very unique color flow filling pattern where it looks like, or there is two directions of blood flow within that same vessel. So here's that vessel. There's that intimal flap separating your true lumen and your false lumen. And we see blood flow with two different colors. So we know that normally doesn't exist, in a vessel unless we have something going on. So in this case, let me see, we got blues are away, reds are towards. So in this case, the reds indicating blood flow, going in that direction. Blue blood flow going in that direction now. So what's going on probably here is, we got blood flow coming through that vessel, going down the vessel. So this is probably, where are we? We're in aorta. All right, so blood flow's going that way. So aorta, so this is going to be our true lumen, blood flow heading in that true lumen. And then our false lumen, blood flow is entering in, hitting the end of that dissection, and then reversing back out. So we see that evident as in, with two different colors now. When we Doppler these, you'd also be able to tell right away, which is your true lumen, which is your false lumen. The true lumen will have a relatively normal looking arterial tracing, whereas the false lumen will look completely funky. You'll be like, that looks very strange. It'll be like the wrong direction and it'll look very, very odd, not your normal arterial tracing. So another example of true and false lumen now. So this is with a carotid artery dissection. So in this case, blood flow is going to be going in this direction. So red is towards, so it should be going, this is going to be our true lumen, and then the blue representing that false lumen with blood flow flowing in the opposite direction. Here we can see the transverse of that dissection with the intimal flap. So with pseudoaneurysms now. So with pseudoaneurysms, we said this is a result of typically a result of a catheterization procedure where they've gone in and punctured the artery. Patients could potentially develop a pseudoaneurysm spontaneously. Maybe they've had weakening of the area. maybe they were born with some sort of congenital malformation. But typically, it's gonna be a result of some sort of either penetrating trauma or more likely a catheterization, something that entered into the artery, poked the artery and created that hole within the artery. Since there's that hole in the artery, the blood flow is gonna escape out through the neck of that pseudoaneurysm, and the body's gonna try and encapsulate it and prevent that bleed from spreading out by creating a hematoma or collection of blood. So what happens is with each cardiac pulsation, blood flow travels down the artery, enters into that neck of the pseudoaneurysm, gets ejected out into the hematoma. And then as it enters into the hematoma, it swirls around and then exit back out of the neck. So we get this flow pattern where blood flow enters in and exits. So in that neck, we get a very distinctive flow pattern. So it's a bidirectional to and fro flow pattern. So during systole, blood flow enters into the hematoma, swirls around, and then during diastole, it exits back out. So this is that typical, prototypical yin-yang flow pattern that we see within a pseudoaneurysm. So we have the native vessel down here. So this is the native artery, femoral artery, the neck, which feeds that hematoma or that pseudoaneurysm, and then the bidirectional flow, one wound downward, which is going to be seen in the neck. With this one, you notice that there's just color here, and then there's areas of anechoic black kind of surrounding it. So the actual hematoma is probably much larger. We're just not seeing it. Maybe it extends out, something like that. But this is all thrombosed. It's already clotted already. And then this is just the area that's still actively bleeding. We're going to see in a moment that, we have to correct this pseudoaneurysm. So there's a couple of different methods that we can do. We can either hold compression over this pseudoaneurysm to try and completely thrombose this hematoma. So once this whole hematoma becomes clotted off and there's no active blood flow within it, the vessel itself should eventually close off and heal and seal off. And then, we just have this large area of clotted blood, within the muscular compartment. And then the artery is sealed off and closed off. So we can either hold compression over it until that happens, or we can go in there with a special medication called thrombin, and with a needle inject this area that's actively bleeding to cause it to instantaneously clot off. That's where you guys actually come in. It's done under ultrasound guidance. So you'll be guiding the interventional radiologist you'll be scanning over the pseudoaneurysm. As they put the needle in, you're going to be looking for the needle tip when it's actually in the hematoma, in the pseudoaneurysm that's actively bleeding. They'll inject that thrombin medication, and this will instantaneously clot off, thus sealing off that artery and healing that pseudoaneurysm. Yeah.
Would the first step always be compression, or depending on how severe the pseudoaneurysm is, we just kind of can skip that and know that you have to?
It depends for a couple of things. The width of that neck, the length of the neck, how close it is in proximity to that native vessel. So if I have a pseudoaneurysm that has a very wide neck, there's a higher chance that some of that thrombin medication can get into the native artery and then clot off that native artery, and then you're in a world of trouble. Like you're sending that thrombin medication that instantly clots blood circulating through that patient's body. So that's why when you do this study, you're going to take the diameter of that length, how wide it is, the length of it, how far away it is from the actual native vessel itself. Because again, it's in very close proximity and it's a very wide neck. That thrombin injection might be contraindicated. They might not want to do it. And then in that case, they will try and hold compression. If that doesn't work, they might have to go to surgery to actually repair that. Yeah.
It's not related. I have an option.
Okay.
That's right. Walk road too.
Okay. Yeah. I'm recording everything. So yeah, you're good.
When pseudoaneurysm arises, is it possible to have another one in the same spot due to like weakening of the vessel? Is that likely?
Yeah, these can actually become multi-lobed. Like I've seen like massive pseudoaneurysms that are very complex and complicated. And so you'll have your native vessel and then like a thin neck leading to one pseudoaneurysm, and then another neck connecting to like another pseudoaneurysm, and then like another neck connecting to like another pseudoaneurysm, like maybe somewhere over here. So like they could be multi-lobed. So they can be very complicated. Let me see if I have a multi-lobe one. Yeah, there you go. So you can have artery, pseudoaneurysm, next, no pseudoaneurysms, they can be multi-lobed like this. The theory, well, what happens is you try and just hit that top one and this eventually clots off, closes off, closes off, and it kind of just works its way back to that native vessel. So if you treat that more superficial one, it eventually will treat, you know, all the other pseudoaneurysms. So we said that the neck of the pseudoaneurysm where it connects to the native artery. So again, that's another thing. Pseudoaneurysms are just arterial. So it just will happen off an artery. Pseudoaneurysms do not happen off veins. So just again, keep that in mind. This is strictly an arterial, something strictly arterial in nature. When we Doppler the neck, we're gonna get this bidirectional flow pattern, this to and fro flow pattern. So again, during systole, we get a spike of blood coming in, and then during that diastole, it exits back out. So we'll see back and forth when we Doppler that neck. So this is one of the critical Doppler tracings that you have to get when you want to make that diagnosis of pseudoaneurysm. So here they are Dopplering the neck. We got that bidirectional flow pattern. I wish I had the sound of it. It's a very distinct sound. It's very violent, the flow that's through it. You know, it's very high velocity. So you honestly hear this like, and like I could tell it's a pseudoaneurysm from down the hall. I'm like, oh, you got a positive pseudo, you know. So again, these pseudoaneurysms. So in this case, this is the part that's actively bleeding. This part is probably thrombosed as well. So it's a partially thrombosed pseudoaneurysm. So for you guys, you're going to be measuring, you know, the size of the pseudoaneurysm when you have to take your measurements, you know, so we'll just do like a singular one. And you'll measure in multiple planes as well. So, you know, you'll be like, you know, your sagittal measurement, try and measure the longest length, your width of that pseudoaneurysm. So you'll measure the whole hematoma. If it's partially thrombosed, you'll also measure, you know, the part that's still actively bleeding as well. So you're going to give the doctor some of those measurements. You'll do it in multiple planes in sagittal and transverse. Your measurements. In addition to that, we said we're going to measure the width of the neck. So measure size of pseudo. Measure width and length of neck. And then Doppler neck. For to fro. How do you spell to and fro? To and fro. O-U-R. Fro. You guys are gonna learn my spelling's atrocious. So again, we're looking, oh, there we go, fro. So again, we're gonna want to measure the diameter of that neck. So it's very narrow. Greater than 2 millimeters, it's probably contraindicated, but leave that up to the doctor. So if you have a neck that's wider than 2 millimeters, they might not inject it. Again, like I said, if the neck is very short and very fat, when they put that needle in to inject it, they have a higher chance of that thrombin medication getting into the actual native vessel and causing some issues. So something like this, probably not going to inject. Actually, no, you definitely shouldn't be injecting that. That neck is very, very wide, and that's right up against your native artery right there. We're trying to stick that. This is probably, if I had to guess, that's probably radial artery. Maybe they did a radial artery tab. That looks like down in the arm. That would be something that you can compress. I mean, look how close you are to the surface of the skin. So it's literally right under the surface of the skin there. So that'd be something that you probably have to compress. So again, we're gonna nice bidirectional flow pattern. When they Doppler the neck, measure the diameter, the size of the actual pseudoaneurysm itself. Looks like here they were again Doppling the neck, that distinct bidirectional to and fro flow pattern. So in this case, they were doing the ultrasound and they saw the large collection here. Here's the artery and vein. And there's no connection, there's no blood flow within it, there's no color flow. So this would be a completely thrombosed hematoma. So that's good. So this patient, it healed themselves. Either maybe they held compression for a little while longer, it healed off, or maybe this is post-procedure after that thrombin injection. So again, this was post-catheterization showing a multi-lobed pseudoaneurysm, like I said, so they can have multiple actual hematomas or pseudoaneurysms with multiple necks. This is where it gets a little more complicated. And I would start with superficial and just work your way deeper. So this would be one, so pseudo one, pseudo two, as you work your way. Just keep in mind, these pseudoaneurysms can also be posterior to the vessel as well, so they could be deeper. I remember there was one guy, the CT said he had a pseudoaneurysm. I'm scanning where it normally should be, in the groin. I'm looking, I'm like, I don't see this thing, I don't know what's going on. And it turned out the actual pseudoaneurysm stuff was way off to the side. There was a thin neck that was running all the way out to the side. I was like, good God, I would have never found this thing. Unless I actually sat down and looked at the CT images itself. I was like, I went to radios, like, I don't see this thing. He's like, oh, that's why you don't see it. It's all the way out here. So again, just keep in mind with these pseudoaneurysms, there could be a very long, thin neck that connects to that hematoma. I'm gonna skip ahead real quick and just go into official exams, therapy connection, directomy, angioplasty, thrombin injection. So kind of just tie into thrombin injection. So we said treatments for pseudoaneurysm could be compression or thrombin injection. So we can use ultrasound to guide where we actually compress, ensure that we actually are compressing the aneurysm itself. So that may be holding the probe, compressing with the other hand, or actually using the probe itself to compress the pseudoaneurysm. So we said the size and location of that pseudoaneurysm, and particularly the neck, determine potential treatment. So we want to again see how close it is to the native artery, how wide that neck is, how long that neck is. Again, that might determine whether or not we actually perform the thrombin injection versus compression. There is a closure device that the hospitals could use. This is a femstop device. It's basically a collagen plug that they use to try and plug the vessel. Or they can perform this thrombin injection. Again, that's done under ultrasound guidance where they inject the thrombin medication directly into the pseudoaneurysm. Funny part is when you get those little vials of thrombin medication, it literally says on the bottle, do not inject. I don't know who the doctor was that figured out, hey, we could do this to cure this condition, They obviously weren't following protocol. So thrombin injection, we said this is done under ultrasound guidance. So you'll do your initial exam. You'll show that it's positive for pseudoaneurysm. You'll take your measurements. You'll do everything you need to do. And then the doctor will, decide, all right, are we going to inject this now? We're going to bring the patient back maybe a little later in the day. Either way, this is a ultrasound guided invasive procedure. We are sticking a needle into the patient, so it's an invasive procedure. We're injecting, the thrombin medication. So, consent does have to be obtained prior to doing this. So the patient has to consent to it. So you'll start with your color on, visualize the pseudoaneurysm is active. You'll take your color Doppler off. That'll allow for better visualization of the needle tip. And the radiologist or the interventional radiologist or the doctor's gonna be coming in kind of from an angle. And they're gonna be inserting the needle with that contains that thrombin medication directly into that pseudoaneurysm. So ideally, you wanna be as far away from that neck as possible with that needle tip. So you wanna be in that kind of the more superficial portion of that pseudoaneurysm where it's bleeding. And then the doctor, you'll be, guiding the doctor. They'll be looking at your screen as well, but you'll tell them, all right, you're in you're in the aneurysm itself. If they go too far, you'll be like, all right, pull back just a little bit or angle a little more superficial to kind of get in this area over here. All right, you're good. And you're good to inject, doctor, and then he'll inject the medication. And as soon as he does that, this will instantaneously thrombose. So literally, in a matter of a second, that becomes clotted. You'll put your color Doppler back on, show it to the doctor, I'm sorry, I'll take a step back. You're also gonna be taking some clips. So you'll take a clip of the needle actually in there to prove that you're in the pseudoaneurysm to document it. You'll take a picture, with and without color after the procedure. So you'll say post injection, needle's still in there, no blood flow, that it's been successful. And then at the end of it too, after the doctor removes the needle, you'll take an image for that native artery showing that there's blood flow in the actual native artery, that you haven't thrombosed that as well. So those are all parts that go into the actual pseudoaneurysm study. I'd say probably 95% of the time, first shot is sufficient. They don't have to come back. They'll come back to your department usually the following day just to ensure that it's still thrombosed. They'll do a quick follow-up ultrasound. So I say 95% of them, they're good first time doing it. Sometimes they might have to re-inject again, do it a second time. Maybe it was a larger pseudoaneurysm, that required maybe a little bit more thrombin. That patient also has to lie very still after this procedure too. They don't want them up and walking around. They want to give this a chance to heal. But again, most of the time it's just one and done and they're good. Simple procedure, literally it takes 2 seconds. So this is just showing before and after, thrombin injection. So before, this is all actively bleeding, and then post thrombin injection, you see it's now no blood flow, no color, and it's completely thrombosed. Another post pseudoaneurysm thrombin injection. So before, documenting the bidirectional flow in the neck, actively bleeding, the needle coming in to that pseudoaneurysm, they inject the medication, and then post another image that you're going to store again, showing complete thrombose. And then that's a nice image because you got your native artery right underneath it, documenting that there's still flow, post injection in that artery. So this is again done under sterile technique. It's ultrasound guidance. So you'll get some practice. So when you guys get to the vascular lab, see if you can try and observe one of these. You might be fortunate enough to help assist the doctor in it. I know the doctors in my hospital back in New York, they used to have the students like hold a little vial of thrombin medication, like upside down as the doctor draws it out, or they'll set up the trays and everything and create the sterile field for the doctor. So you're not going to be as students, the one actually holding the probe, they don't want that, which makes sense. But again, you as a sonographer, you're gonna have to put sterile gloves on. So, that's can sometimes be a little tricky. Put on your sterile gloves, maintain that sterile field, and you'll have one hand that's, sterile while you're operating the machine, getting the pictures. Let me go back. Yeah.
The spot for you to make sure your probe isn't in the way of the physician who's injecting the product.
You're going to be directly over the pseudoaneurysm, and they're going to kind of come from the side.
Oh,
So
they're
like,
going around us.
yeah, so they're going to come in from the side and like inject down like that. So yeah. Some transducers and probes have a guide on it. So there's like an attachment clip that you can attach to the probe. So like we have sterile probe guides. So like you'll have your sterile cover over it and then a probe guide that's sterile that can attach over it. And they can actually put the needle in that guide. So that's maybe more rookie, radiologist that uses that. Some of them are really good. Like I've had radiologists that have been like Dr. Hahn, he was like a ninja assassin. like Dr. Hahn, I don't see a needle tip. He's like, screw it, I think we're in. Robin, I'm like, oh God. So yeah, I told you we were in. Sometimes, yeah, so he could kind of feel it out like himself. Yeah, Dr. Hahn, he's the best. She's like, what the hell are the nurses? I'm like, I don't know, they're coming. They said to be 5 more minutes. I'm like, I don't have time for this. Like, Dr. Hahn, we haven't even got consent yet. Like, they'll do the whole procedure and then the nurse will come walking in, like, because there should be a nurse present for it. And be like, did he do timeout? Yeah, we did timeout. Did we get consent? Yeah, we got consent. They'd have to backtrack their logs. They would get so pissed at him. All right, so peripheral arterial disease. So we're going to discuss a couple of non-atherosclerotic lesions or non-atherosclerotic causes of narrowing of the vessels. So these may include inflammatory diseases, congenital abnormalities, injuries, as well as some acquired diseases. So we'll go over each one of these in detail: arteritis, Raynaud's disease, vasospastic disorders, popliteal entrapment syndrome, compartment syndrome, Rascalvis syndrome, Bluetooth syndrome, coarctation, and then arteriovenous fistula, AVF. All right, so going to medical terminology, that ending itis refers to inflammation, swelling. So anytime I see itis attached to anything, I just think of inflammation or swelling. So when we're talking about vasculitis, it's also known as angiitis. So this is just a general term for swelling or inflammation of the blood vessels. We can get more specific when we're talking about, arteries versus venous. So this vasculitis, it's idiopathic, but may be related to an immune system being hyperactive. So this inflammation of the vessel wall causes vessel narrowing. So you think of your arteries or your vessel walls, as being relatively thin in comparison to the actual, vessel itself. So like our normal vessel walls going around. So we have our normal 3 layers. When we have vasculitis or inflammation of those vessel walls, they become very, very thickened now. So that's your normal vessel now. Your vessel wall now becomes quite thickened. And it's thickened uniformly kind of all the way around. So that might not be, this might now be your inflamed, medial layer. And we got a thickened intimal layer as well, coming around a little brighter. So now, patient who has vasculitis, instead of having a nice open vessel, now you have something that looks like that. So there can also be systemic involvement. So these patients might have fevers, weight loss, fatigue, rapid pulse, diffuse aches and pains. So vasculitis, can potentially affect every organ in the body, every organ system. And vasculitis is often very difficult, to diagnose.
What is idiopathic?
Well, idiopathic means that there's no known cause. Well, when something's idiopathic, we don't know why.
Oh,
It's idiopathic. It's kind of easy way out. A doctor goes, "Oh, your condition's idiopathic." That means they don't have an idea what's causing it.
okay.
So idiopathic means unknown cause, or they're not sure. So that vasculitis, then we can get specific when we're talking about arteries, it becomes arteritis. So when we're talking specifically about arteries, that vasculitis now becomes arteritis. So again, the etiology is unknown, but it often involves an immunologic condition or collagen-related disease. So this arteritis can result in thrombosis of the vessel itself. So we get this thickening, this narrowing of the vessel wall. This can also potentially lead to the development of clot or thrombus, depending on how severely narrowed it is. Most patients with arteritis do not present with claudication symptoms, but rather with digital ischemic symptoms. So this swelling, this inflammation, is so severe. It's and it's fairly sudden onset when they develop the arteritis or this inflammation. That it isn't normal like cramping or aching. It's very severe, more digital pain. It's more severe symptoms. So it's intense pain, discoloration. The limb gets very pale or can get very blue all of a sudden. So symptoms include severe pain, skin and intrinsic atrophy, ulcers, ulceration. So the most common form of arteritis is Buerger's disease. Buerger's disease. The medical term for Buerger's disease is thromboangiitis obliterans. So there's that term, obliterate. So that vessel is becoming obliterated. So we're losing the lumen of that vessel where blood flow can get through. It's becoming very narrowed and, obliterated. And we're getting rid of that inner lumen, that channel. So it's a reoccurring inflammatory vascular occlusive disease that affects small and medium-sized arteries of the upper and lower extremities. So it primarily affects the vessels of the fingers and the toes. The patient population that's most commonly affected are going to be males that are younger than 40, associated with heavy cigarette smoking and tobacco use. So one of the ways that we teach students to memorize this with Buerger's disease, think of a young guy goes out to the bar, starts drinking. When he starts drinking, he starts smoking cigarettes, and then he winds up in a diner eating a greasy cheeseburger. So young men, cigarette smoking young men that are affected by Buerger's disease. So it may present with both claudication as well as advanced ischemic symptoms. So this arteritis, this swelling, again, can become so severe that it completely occludes the vessels, completely blocks them off. They can wind up with numbness, tingling in the hands and feet, digital ulcerations, and even gangrene. So again, if this arteritis isn't relieved, this swelling isn't relieved, it can lead to potential development of necrosis and gangrene. It's usually bilateral, so it happens on both both hands or both feet. It's often associated with other conditions like rheumatoid arthritis as well as lupus. Treatments include cessation of smoking cigarettes, administering vasodilators, medications to help dilate the arteries back up. Exercise. So exercise naturally will dilate your arteries. So, exercise, good health will help limit these symptoms for patients who are suffering from Buerger's disease. Sympathectomy. So they can do actually a nerve block to try and block the sympathetic nervous system. So that sympathetic nervous system will actually constrict the arteries. That's part of that fight or flight response. So when you're in that fight response, you're vasostimulated, your arteries are actually constrict, raise your blood pressure. Unfortunately, if gangrene has developed because of that digital ischemia, they would have to amputate those areas that are gangrenous. So this was a example of an artery where we're getting some arterial blood flow coming down, and then it just abruptly stops because that vessel, the walls have become so inflamed where it actually completely closes off. So the vessel walls are all so inflamed now, it's completely occluding that vessel, and there's very little blood flow getting through now. So this was showing an angiogram, patient with Buerger's disease, and you can see abrupt stop of that contrast. So there's actually no blood flow getting to that, what it looks like second digit. they use the PPG sensor, so those, some of you in labs have practiced with the little clips. We can put a sensor on the fingers using that machine and get Doppler tracings. So in this case, it correlates with the patient's angiogram. That second digit here was flat. There was no blood flow getting through it. So this was actually in a female, presented with pain in the first and second digits of her right hand. So you can also compare, there's much more blood flow in the third, fourth, and fifth digits than in the first and second. So second, definitely. The angiogram too for the thumb, there's diminished contrast also getting into that thumb as well. So an example of, how severe it can get. In this case, this vasculitis is now called gangrene on this patient's digits. So these are definitely going to either have to be amputated or debride, well, probably amputated. With Berger's disease on angiogram, the vessels tend to take on this corkscrew appearance from the other arteries that results from the vascular damage, especially in the arteries of the hand. So here's the normal angiogram, and then over here you can see these vessels are taking this like corkscrew appearance. Another form of arteritis. So the thromboangiitis obliterans or Berger's disease is the most common form of arteritis. We do have Takayasu's arteritis. So Takayasu's arteritis has a couple of other names that are associated with it, like brachiocephalic arteritis, arterial syndrome, reverse coarctation, aortic arch syndrome. So with Takayasu's now, we're talking about large to medium-sized arteries. And then the branches that are supplied by those large to medium-sized arteries. So this mainly impacts the aortic arch and its large branches. So Berger's disease, small arteries, hands, feet. Takayasu's arteritis, think the large aortic arch and its large branches now. So things like the subclavian arteries, common carotid arteries. This involves thickening of all three layers of the vessel. Lesions can be stenotic, so that it can be narrowing of the vessel. Can even become occluded as well. So if that swelling is so severe, it can completely close off the vessel. And these vessels can also become aneurysmal. We get decreases in the blood flow that leads to lack of pulses in those areas. So if you imagine, my aortic arch is inflamed and the blood flow is narrow, or the vessel is narrowed, there's diminished blood flow. I'm going to have very weak pulses in my arms and in my legs. There'll also be diminished blood flow going up to my brain. So I might exhibit, potential stroke symptoms. Could lead to temporary paralysis, temporary blindness. So again, if I don't have good blood flow, good perfusion into my brain, could lead to vision disturbances. So again, this etiology is also unknown, so it's idiopathic. The most common population with this is going to be Southeast Asian, the Asian population, and it's usually women as well. So women of childbearing age, usually younger women under 40. So that's the trick with some of these questions, diagnosing, what it could potentially be is knowing also the patient populations that are most commonly affected. So, you'll get board questions, 30-year-old female presents, a 30-year-old female of Asian descent presents with, bilateral upper extremity weak pulses and maybe some sort of stroke symptom, and dizziness or, paralysis or something like that. They'll show you an ultrasound image, and you'll have to make that, that connection that, this is probably Takayasu's arteritis based off of the information that they're giving you. So it helps to know, again, the primary patient populations that are affected by the disease. Treatment in this includes controlling, the hypertension or maybe an implant vascular bypass device. So here we can see a transverse section of that vessel now. And you can see how thickened those walls are with Takayasu's arteritis. So a sagittal and transverse view of that vessel itself, showing the thickening of that wall. These are some more pictures, Takayashi's arteritis. So this was right axillary artery now. So with this form of arteritis, similar to Berger's, the vessels will also take on that corkscrew appearance as well. So you can see that twisting, that corkscrew twisting of the vessel. So we have a 24-year-old female presents with sudden paresis. So paresis is a weakness of the right side of the body, right-sided weakness. The systolic pressure from left arm, 80 millimeters of mercury, right arm 110. So on ultrasound, we see color flow in the common carotid artery, and then thickening of that wall. So we see thickening of that wall within the common carotid artery that we imaged. So the thickening is circumferential, meaning it's all around both sides of the vessel. So again, based off the woman's age, we know this is not going to be atherosclerotic plaque, because again, like I said, that's a slow process that would take a lifetime, to develop. So we know that more likely diagnosis is going to be something like Takayashi's arteritis. So here are just a couple more forms of arteritis. This is polyarteritis. So it's a simultaneous inflammation of a number of arteries. It's also, idiopathic. Patient can suffer from rheumatoid vasculitis. So this is a serious manifestation of rheumatoid arthritis. Generates a severe inflammatory reaction to a blood vessel, which in turn causes damage to the tissue or organ. So another form of arteritis that the boards likes to hone into is giant cell arteritis or systemic giant cell arteritis. So you might also hear this referred to as temporal arteritis. The reason being it primarily affects the superficial temporal artery. So that was actually, one of the branches of our external carotid artery, that superficial temporal artery. With giant cell arteritis, one of the things that you need to recognize, with this diagnosis can only be made by doing a biopsy of that temporal artery. So the doctors actually need to take a little sample or piece of that temporal artery, send it to pathology, do a biopsy of it to make this diagnosis of giant cell arteritis or temporal artery arteritis. Population again is going to be female under 50 years old, so it's typically Caucasian white females under 50 years of age. I'm sorry, yes, under 50 years of age. So patients who are undergoing radiation therapy for cancer, that radiation can also lead to damaging of the vessels and potential, fibrosis, inflammation of the vessel. So it can result in arteritis and acceleration of that atherosclerotic process as well. And just keep that in mind as well, patients who are undergoing radiation therapy for cancer treatment. All right, so vasospastic disorders, cold sensitivity. So the primary vasospastic disorder I want you guys to learn is Raynaud's disease and Raynaud's phenomena. So sometimes this Raynaud's disease is referred to as white, blue, and red syndrome. That refers to the colors which your hand turns when you have this vasospastic disorder. So just think of the blood vessels, they have that muscular layer. So any muscle could spasm on you. So you can wind up with a muscular spasm. So anyone who's got a cramp in their muscle or in their leg that spasms up and that muscle becomes tense and thickened. The same thing can happen with your blood vessels, your arteries in particular, because they have that thicker muscular layer. So when it spasms, it thickens and can constrict the vessels. So this is a condition that causes the body, areas of the body, particularly the fingers, toes, tips of the nose, ears, to feel numb and cold in response to either actual physical cold or some sort of stress stimuli. So again, this can be brought on by, physical stress, anxiety, stress, or stimuli to cold. So in this case, the arteries and the arterioles undergo an intense spasm, thus, constricting the blood vessel. These patients wind up with skin color changes. So they wind up with pallor. That extremity of the hand gets very pale now because that blood flow is being cut off or severely reduced. If it's completely, occluded, then the hand becomes cyanotic. So again, when cyanosis refers to blue or purplish discoloration, so there's absolutely no blood flow getting to that hand now or area of the body, becomes cyanotic, becomes blue. And then on the other side of it, where those vessels have been constricted, blood flow is going to start to build up and it's become very bright red. So that's the rhubarb. So rhubarb refers to redness. So that's why they get that white, blue, red syndrome. So some of that rhubarb can also happen as well as that spasm releases itself. So as that muscle or the muscles in that blood vessel relax, we get a sudden rush of blood going back in. That can also cause the hand or a portion of the body to turn very red as we get a sudden influx of blood again. Patients can have prickly or stinging pain upon warming or relief of that stress. So we get reperfusion of blood flow going back in. So diagnosis can be made off clinical presentation, blood tests. We can use our PVR SLP machine, hook them up to the digits, the sensors to the digits to get readings and pressure measurements. And then they also will perform what's called a cold challenge test, where they'll actually, subject that patient to the stimuli, to that cold stress. So they'll actually literally dip their hand in ice water, try and create, that vasospastic response, and then get your measurements and readings after that that stress, that cold challenge test. It's important for you guys to also know the difference between Raynaud's disease and Raynaud's phenomenon. So if you can write down, primary Raynaud's disease and then secondary Raynaud's phenomenon, it's easier for me to differentiate between the two. So when you see Raynaud's disease, that's just this vasospastic disorder by itself. So the patient has this vasospastic condition by itself. That's primary Raynaud's disease. That's the primary cause of what's going on, is just this disease. When it's Raynaud's phenomenon, secondary Raynaud's phenomenon means that they have this vasospastic disorder in addition to underlying peripheral arterial disease. So this is actually way worse when they have Raynaud's phenomenon than just having the Raynaud's disease by itself. So someone who has Raynaud's phenomenon has this vasospastic disorder on top of an underlying disease. So it's secondary to something else as well. So it's usually peripheral arterial disease. So we'll see in a moment, the tracings that you get are very different. So this is like, all right, they have this Raynaud's disease. It's bad, but Raynaud's phenomenon is much worse. So when they have that vasospastic episode, if they have underlying disease, this is way worse, if you can imagine. So there's already diminished blood flow, and then you're throwing Raynaud's disease on top of it. Raynaud's disease versus Raynaud's syndrome. So you said it's an episodic vasoconstriction of the arteries and arterioles in response to cold and stimuli or emotional stimuli. It's the most common vascular disorder seen in the upper extremities. So when you get patients that complain, their hands are cold or their digits get very numb, they get discoloration, they get very blue or very pale. Same thing with the feet as well. So with that primary Raynaud's disease, it's, again, this condition without any underlying disease associated. It's usually bilateral, so it usually affects, again, both hands. In terms of treatment for primary Raynaud's disease or primary Raynaud's syndrome, prevention and alleviation of anything that could potentially cause that vasostriction, that episode, So that would be wear gloves, wear an extra layer of socks. trying to avoid cold weather, if you can. If it's stress stimuli, trying to avoid whatever stressors it is that trigger you. They can prescribe medications, vasodilators to try and prevent that from happening. Surgery, so a sympathectomy, nerve block to try and, again, prevent that sympathetic nervous response. And then exercise, again, being physically active also goes a long way to promoting good arterial health. There's examples of, patients who have Raynaud's disease. So again, you could see tips of the finger very pale, got the pallor there. So here's where you can obviously tell where that vessel is occluded, where you're getting that spasm occurring. So blood flow is trying to work its way all the way down to the fingertips. The vessel all of a sudden here becomes occluded, very pale, almost no blood flow getting through. All that blood flow is building up on this side. So the hand gets very red. So these would be very cool to touch. This might be very warm. Again, it could progress. So you're seeing some of the digits here affected. You can get areas that become very cyanotic now if it's you have prolonged period where there's diminished blood flow. So white, blue, and red syndrome, Raynaud's disease. So secondary Raynaud's syndrome or Raynaud's phenomenon. So we said this is a mix of vasospastic disorder, the primary Raynaud's disease, in combination with some sort of intraluminal obstruction. So this is, again, patient has something obstructing the blood flow, primary obstructive disease. So most likely atherosclerosis. So we have arterial obstruction in large or small arteries, plus that vasospastic disorder. So we said now this is more serious than having just the primary Raynaud's disease. So again, treatments for this now include, removing, same thing with Raynaud's disease, removing the stress or the stimuli. So whether that's cold or stress, trying to treating that primary disease. So if we know it's some sort of atherosclerotic plaque or narrowing, we can try and correct that area of narrowing. So it might involve, surgical repair of that. We're just kind of showing the steps in progression, as the hands change color. So in terms of primary versus secondary, then look at the age populations as well. So primary Raynaud's disease is mainly females under 40. That's that vasospastic disorder. And it's idiopathic. And then we got the combination. So then we're talking more, the older population could be male or females. And then they have that underlying occlusive disease as well. So we'll touch back on Raynaud's disease when we get into upper extremity PVRSLP and looking at that, but going into popliteal entrapment syndrome. So this condition now is compression of the popliteal artery by the medial head of the gastrocnemius muscle, and the adjacent tendons or fibrous bands. So we have the picture of the knee, the femur, the tibia, popliteal artery coursing through, and then this is the proximal head or superior head of the gastrocnemius muscle as it inserts, into the distal end of the femur there. It's usually related to a congenital anomaly, so a malformation, of the artery, the tendons as it relates to the way the artery runs. More commonly found in young men. Most of the time it's bilateral, so both sides are affected. So with this, we have repeated extrinsic. So that term extrinsic means from the outside of the vessel. So we get repeated outside compression, extrinsic compression of that artery over and over. That can lead to potential aneurysm formation, the development of thrombus or arterial thrombosis. So basically every time the patient, bends their knee, so they're exercising, they're walking, they're running, we get stretching of that muscle that compresses the artery. and entraps and pinches the artery. So we're getting repeated, compression and damaging that artery in that area as it runs, underneath the muscle there. So if we think, we have a young, active, healthy, fit male that's coming in with symptoms of claudication, that doesn't make sense. Why is this patient experiencing, cramping in their calf? When they're young and healthy, they're active, they're exercising. We have to find, they have no underlying risk factors. One of the things that we can look for now is suggestive of popliteal entrapment syndrome. So they might have numbness, tingling, paresthesia on the foot, pain in the calf. So with this, we can use ultrasound to image the popliteal artery at rest. And then with after plantar flexion, so we can have them, flex their toe, try and stretch that calf muscle. And then while they're doing that, we're imaging the popliteal artery and we're looking for changes, in velocity between rest and then active plantar flexion. We can use our PPG sensors and our PVRSP machine as well to look for changes in blood flow as well. And then we can also, recommend an angiogram, so digital subtraction angiography or an MR or CT to also image the areas. So this was showing they were Doppling the popliteal artery. So we had a nice normal healthy tracing, nice triphasic flow, normal velocities. And then we had them perform that plantar flexion, and that actually compressed the artery. And now the velocities, it's kind of hard to see, but they go way up. So it looks like over here they were measuring less than 100, maybe around 90 or 83 centimeters per second. And then with that plantar flexion, the velocities increased, they went up to 130, meaning that the artery is being compressed and narrowed. So we're getting those elevated velocities. So we can place our sensors on the digits of the feet and, have the patient do the same thing, plantar flexion, dorsiflexion, and we can see that we get diminished blood flow. So your right foot's not affected, so right leg's not affected, but it's the left, that's being affected in this case. So both plantar flexion and then dorsiflexion, we can see diminished blood flows when we compare resting to, as well as comparing to the right side of the right lower extremity. There's another condition called adventitial cystic disease. So these are actual cysts that grow in the outer layer, the adventitial layer of the vessel, that can lead to actual compression of the vessel. Then this is just another rare condition. Chances are you guys aren't gonna, be encountering something like this. But if you do, it's more common in males, between 40 and 50 years of age. And because these cysts grow and develop, they will actually compress. So here's the actual vessel where the blood flow is going through, and this large cyst is developing in the outer layer of the vessel that's actually compressing it out. So this is a popliteal artery with that cystic adventitial disease. So here's the actual popliteal artery itself, and then this large cystic area that's developing the outer layer of the vessel that can actually compress it. Compartment syndrome. So this is compression of the nerves and blood vessels within an enclosed space that leads to impaired blood flow and muscle and nerve damage. So it's caused by swelling within this osteofascial compartment of the leg or arm. So think of we have various muscular compartments in our extremities. And this swelling is typically caused by some sort of trauma or accident. So typically like some sort of motor vehicle accident or some sort of blunt force trauma. So maybe you pissed someone off, they took a baseball bat, swung it at you. You're a high school student playing lacrosse ball hits you in the thigh. You wind up with swelling, in that thigh as a result of the trauma. So that swelling in that compartment could potentially be enough to actually compress the blood vessels, compress the nerves, and lead to, potential nerve damage. So we get swelling within that compartment the pressures within that compartment start increasing, leads to compression of the muscles, and thus the compression of the muscles then presses on the blood vessels and nerves. And it could either severely diminish or completely eliminate blood flow through that compartment. So it can block the blood flow from passing through that compartment where the swelling is occurring. That could potentially lead to permanent injury of the muscles and the nerves. And the limb may die and need to be amputated, if it isn't corrected. So it is a serious condition when we're dealing with compartment syndrome. So symptoms include severe pain that doesn't respond to elevation or lowering the legs or pain medications. There's paresthesia, so that burning, tingling, numbness, weakness of the involved muscles, tension of the compartment. So they might lose sensation of the nerves, so sensory deficits in the affected areas, loss of pulse. So they'll actually monitor the pressure within that compartment, so they can tell the pressures within that muscular compartment. They're monitoring them, and when they get to a critical level, they actually have to perform a fasciotomy. So they actually do a surgical incision, open up that muscular compartment to try and relieve the pressure within that compartment. Yeah,
Know all about it.
she knows all about it. So she actually had compartment syndrome, both legs.
Bilateral fascia.
Yeah.
And it goes through exertional, so I feel like a lot of times you hear about it, it's trauma based, like you said, like an
Yeah.
accident. But they've like found out over time it happens with like chronic exercise, that you have like, so they think I had some sort of trauma from running. I just was in high school and I could never figure it out. So over exertional use, then they kind of put it together and they did a pressure test like they're talking about. And they
What did it look like when they took the pressure measurements? Like
the needles are really long.
Yeah.
I remember, and it's a little uncomfortable, not
Yeah.
painful, but uncomfortable.
Yeah.
And they're just super long, kind of scary when they go in. But,
it's almost like if you think like a meat thermometer.
Yeah.
Almost. And
yeah.
let's take your pressure. Yeah. So this is showing a patient, with compartment syndrome. So the main thing is comparing the symptomatic side to the asymptomatic side, so you know what your normal baseline will look like. So this was a patient with calf swelling. So they Dopplered the posterior tibial artery proximal to where the swelling is, so above that compartment. They got a Doppler tracing. So with this Doppler tracing, we look at this. This is very high resistance. So there's absolutely no diastolic flow. There's nothing going on during diastole. So systole, we get a blip of flow, but during diastole, there's nothing going on there. So that means something is compressing that artery further down, that's stopping that blood flow dead in its tracks. And that's the swelling of that muscular compartment. We go below the level of the swelling now, we see a monophasic, much lower resistant blood flow. And that makes sense. The body is now starving for blood. The blood vessels below that compartment are vasodilated, trying to draw in as much blood flow as it can to feed the tissues. So it makes sense the body's going to have the low resistant flow pattern there. So that just makes sense. This is what the body's, physiologically what's going to happen. We have very high resistant above it, very low resistant below it. And then when we compare that same level, on the other side, we get a nice triphasic waveform. We got some diastolic flow. So this is what normal should look like. So comparing right to left, we know automatically right away, all right, this is most likely compartment syndrome. We got very high resistance above it. We can try and image through it, demonstrate where there is no blood flow, and then below the compartment, below the swelling, that's what we see. We're gonna just do a couple more. I'm gonna kind of cut it in half. We'll do TOS, Fluto, and Cork. We'll leave AV fistula for next week. I'll play around with next week too. You guys, I think I've reached your limit. All right, thoracic outlet syndrome. So this is compression, either partial or complete, or irritation of the neurovascular structures in the thoracic outlet. So again, we have blood vessels, we have nerves. So this is the brachial plexus nerve that are all running through this thoracic outlet. So we have our first rib. We have this pectoralis minor muscle. So we get the blood vessels that are running underneath that muscle and over that first rib. We also have our clavicle that's involved as well. So it could be compression, by the clavicle or that first rib. These patients will present with numbness, tingling, or pain in the arm that's associated with inactivity or with elevation or hyperabduction. So typically there's going to be a symptomatic position. So it might be someone who's like a painter or construction worker. When they put their arms over their head, all of a sudden their arm, they can only do it for a momentary period of time before their arm starts to get numb and tingling or feels dead. If it's an athlete, so oftentimes you might see this with the pitcher, that repetitive motion of pitching, they'll could potentially develop, thoracic outlet syndrome. So from that repetitive motion of pitching, they get compression of the vessels or the nerve. So again, it's typically associated with exercise or, some sort of repetitive motion. The treatments for this, could be corrective exercises, change in posture, or surgical decompression of that thoracic cavity. So in more severe cases, they will actually remove the first rib. So it's a very invasive surgery where they have to remove that first rib. So, when it happens to an athlete, particularly like in a Major League Baseball pitcher, when they have to go through that procedure, typically it's career ending. Most people don't come back from thoracic outlet syndrome, that major corrective surgery. With thoracic outlet syndrome, just keep in mind that it may not be vascular in nature. In fact, oftentimes it's the nerve that's being affected and compressed. So that patient's symptoms are more nerve related than actually vascular related. So just because, you want to rule out TOS and you do your arterial study, you look at the veins, you look at the circulation, everything looks normal. They still have their symptoms, even though your test is normal. It might be the nerve that's involved. So here's blue toe syndrome that I mentioned before. So this is caused by atheroemboli, so small pieces of that atherosclerotic plaque that break off and embolize. So we're going to learn all about atherosclerotic plaques. There are different types of plaques. Not all plaques are created equal. There are certain plaques that are more susceptible to breaking apart and embolizing. So these are what we're referred to as ulcerated plaques. They embolize, and little pieces of that plaque travel down the arterial system, and they get lodged in some of their smaller arteries distally. So typically in the feet or the hands, the fingers. And this will lead to ischemia where that piece of plaque gets lodged. So they get stuck in these small distal vessels, these small distal arteries, and can lead to ischemia and, cyanosis and potentially even gangrene if not, corrected. And the last one I wanted to talk about is coarctation of the aorta. So this is another, again, non-atherosclerotic lesion that can cause a stenosis. So this is a congenital defect. So this is something, a child or a patient is born with. So it's a condition in which the aorta is pinched or constricted or narrowed at some point along its length. So the most common location where we see coarctation of the aorta is going to be in the isthmus of the aorta, so just past the level of the left subclavian. So it's in that aortic arch or descending thoracic aorta, just distal to where the left subclavian branches off. So again, we said it's congenital. The child is born with this, so this is typically gonna be something that's gonna be diagnosed early on. Might be diagnosed, in the fetal ultrasound. So while the mother's still pregnant, they might know that this child has coarctation of the aorta. The other way they might diagnose it or find it is when they try and take that baby's blood pressure, and their blood pressures are through the roof. They check one arm, they check the other arm, both arms are very high. Like, all right, that's weird. And then the doctor or nurse will then take a blood pressure down by the ankle. And that ankle pressure now is very, very low. So if you kind of just think about it, this is where my narrowing is. Pressure is going to be build up on that side of the aorta because I have that narrowing now. I'm grabbing the aorta, we're pinching it, we're squeezing it. Blood flow is going to build up on that side. Pressure is going to build up. Those pressures are going to translate, into your left subclavian artery, which works its way down to the brachial. So you'll have left brachial pressure. It's going to go back up the innominate or brachiocephalic artery into the right subclavian to the right brachial. So both arms, you'll have bilateral elevated brachial pressures. But then on the other side now, the pressures are going to be very, very low. So we've lost all that energy now from the heart. Blood flow is diminished through the rest of the body now. And that works its way all the way down towards the legs. So anything on the other side of that narrowing is going to demonstrate very low pressures. So we can tell right away, when this baby's born, they have very high pressures in the arms, very low pressures in the legs. Where that comes into for you guys with that exam there, boards might throw a question at you. You have a young patient, 20 years old, no symptoms. I'm sorry, no risk factors. I don't say no symptoms because they're coming to you, they have symptoms, but they have no risk factors. They don't have hypertension, they don't have cholesterol, they're not smoking. But you do the PVR SLP and they have very low pressures all through their legs. And their arm pressures are sky high through the roof, both sides. Right away that patient that you have most likely has a coarctation of the aorta. So they want you to kind of connect those dots now. This is when you guys become the I don't say become the clinician, but like put your sonographer hat on, all right, what's going on here? Be the detective. Because that's really what we are. We're detectives. In the end of the day, we're the ones trying to help the doctors make that diagnosis based off the clues. So with this, surgical repair is done. So again, they know very early on that this child or this baby has a coarctation. They're going to go in there with balloon angioplasty and they'll balloon that open up that narrowing, maybe place a stent there to keep it open as well. And then that's the end of that. Fistula, we will get into. How was that? Much? Great.
Started recording the session.